Thank you to the IRI Trivandrum Club for giving me this opportunity to speak on this topic of prostate imaging and demystifying PIRADS. So the topics that I wish to cover are basic anatomy, something about prostate cancer pathology, imaging, primarily MRI, the PIRADS recommendation, the latest updates on PIRADS imaging, version 2.1, the image interpretations with respect to the updated changes, and a few recent advances. So we all know the prostate is an inverted pyramidal structure, weighs about 20 to 40 grams, has a glandular tissue as well as fibromuscular tissue. Histologically, the prostate is divided into 4 zones. The transitional zone, which surrounds the prostatic urethra, has about 5% of glandular tissue. The central zone has about 20% of glandular tissue, and the most important, the outer peripheral zone. Excuse me. Hello. Shall I continue?
Yeah.
Yeah. Okay. So the most important is the outer peripheral zone, where about 70 to 75% of all prostatic malignancies arise. There is also another important area which is called as the anterior fibromuscular stroma, which does not contain the granular tissue, but is now important with more upcoming research. This is a 3-dimensional depiction of the prostatic urethra. This is the cranial end, this is the distal end, and these are the 2 seminal vesicles, which along with the vas deferens fuse to form the ejaculatory ducts and drain into the verumontanum of the prostatic urethra. So there is this transition zone of tissue which surrounds the prostatic urethra, and this transition zone is the one that hypertrophies as we grow older in males and form the benign prostatic nodules. Surrounding the transition zone is the central zone. The central zone surrounds the prostatic urethra posteriorly, and this central zone is actually an atretic seminal vesicle. Surrounding the central zone is the peripheral zone, which extends from the base of the urinary bladder up till the apex. Here we have to note that the central zone is still visualized at the base of bladder. So the topmost sections of the prostate will show a part of the central zone. There has been a terminology and usage of the central gland, which included the peripheral zone and the central zone. However, that terminology of central zone is now abandoned. In addition to the peripheral and the central zone, there is the anterior fibromuscular stroma. This fibromuscular stroma does not contain any glandular tissue, but can be infiltrated by the malignancy arising from the peripheral or the transitional zone. These are the axial, sagittal, and coronal sections of the normal adult male. We can see a homogeneous T2 hyperintense peripheral zone. Same on coronal. We can visualize the central zone, which is a dark T2 hypointense V-shaped band seen on coronal imaging. And on sagittal, we can appreciate the central zone, the transition zone anteriorly, and the peripheral zone posteriorly. Coming to axial anatomy of the prostate, at the base of the bladder, we will be able to visualize, as I've already mentioned, the peripheral zone seen laterally with a small tissue of hypointensity, which is demarcated at the central zone. The transition zone also is seen sometimes in the topmost sections, which is surrounded by the which surrounds the ejaculatory duct. Coming to the mid gland or the mid level of the prostate, we can see both the peripheral zones as well as the transition zone. It is at these areas that we try to see the neurovascular bundles, which are located at 5 and 7 o'clock positions. Further inferiorly, when we reach the distal part of prostatic urethra, it is predominantly the peripheral zone that surrounds the prostatic urethra with a part of the anterior fibromuscular stroma. Coming to the diseases that affect the prostate, the predominant and most important are the prostatic adenocarcinoma and chronic as well as acute prostatitis. Other benign diseases are also there. For example, this was a curiosity for me when I was searching the literature. When we see a large T2 hypertension, multiloculated mass-like lesion which distorts the entire prostatic parenchyma, this could be this is supposedly a prostate adenoma. Another important variant of adenocarcinoma of prostate is the mucinous adenocarcinoma. When we see a heterogeneous, large, bright T2 hyperintense lobulated mass which replaces the prostate, there is a good chance that this is a mucinous adenocarcinoma. So coming to the prostate cancer, it is the most common primary malignant tumor in males, and it is the second most common cause of cancer death in men. Primarily a disease of the elderly male. Clinical presentations are an elevated PSA greater than 4, abdominal, digital rectal examination, lower urinary symptoms, hematuria, and back pain. A word on the pathology of prostatic adenocarcinoma. The glands in prostate on specimens, that is either true cut or on total prostatic resection specimens, are graded into 1 to 5, with 5 being the glands which show the most amount of dysmorphic cribriform pattern. So when a pathologist receives a prostatectomy specimen, he will grade the tissue based on these 1 to 5 and give a grade that is predominant within the specimen. So if the predominant specimen is 5, the grade would be 5. He will then look at the second most predominant pattern of cells that is seen and grade that. So supposing if the second most predominant pattern is 4, then the Gleason score would be 5 plus 4. Now this is also called as the Modified International Society for Urological Pathology Gleason scoring system. Now the importance that we should know is that clinically significant prostatic cancer starts from 3 plus 4 up to 9 to 10. Anything which is 3 plus 3 and below is not clinically significant prostatic cancer. So if we are imaging, our intention is to pick up lesions which are at least 3 plus 1 and above. Any lesion which is 3 plus 3 or less, the chance of malignancy is about 3% over a 20-year period. So definitely not significant. Routinely, prostate is imaged by transrectal ultrasound, and transrectal gives a good image of the prostate with some zonal anatomy where the peripheral and the central zone are slightly more echogenic than the transition zone. However, it is not primarily used to diagnose prostatic malignancies. There has been some use of prostate elastogram, but it has not taken up in routine practice. It is transrectal ultrasound for prostate is usually done for primary or secondary infertility in males to visualize the ductus deferens and seminal vesicles to see if there is any obstructive lesions. So coming to the main subject, that is prostate MR, clinical considerations. Earlier, it used to be said that if a patient has undergone a prostatic biopsy, we need to have an interval of 6 weeks before we image the patient. That has slowly fallen away because the logic behind that is if there is hemorrhage which will degrade the imaging at that site, that area would already have been biopsied. So if we are not able to see any lesion at the site of bleed, that lesion would already have been targeted by a transrectal biopsy. When it comes to patient preparation, no significant preparation is required. Injection like buscopan and antispasmodics may be useful if there is motion artifacts seen from bowel peristalsis. While reporting an MR of the prostate, we should always have the recent PSA value, the PSA history, as well as the date of biopsy and Gleason score if the biopsy has been done. Prostate imaging reporting and data systems, PIRADS. This was introduced in the year 2012 by the European Society for Urogenital Radiology. This is a work in progress. Currently, we are at PIRADS version 2.1 iteration, which was published in 2019. This helps in the standardization in acquisition, interpretation, and reporting of prostate MRI. It also helps in significantly reducing the inter and intra-observer differences between the reports. And more importantly, for us as radiologists, it is fast gaining acceptance among all urology societies. So urologists around the globe are now taking PIRADS seriously and are referring patients to radiology for PIRAD staging. PIRAD staging has assessment categories, and the main aim for us is to diagnose the probability of clinically significant cancer. So as I had earlier mentioned, clinically significant cancer is Gleason's or ISUP score greater than 7, that is 3+4 or above, and a cancer whose volume is greater than 0.5 ml, and if there is extra prostatic extension. PIRAD staging categories start from 1 to 5, 1 being the very low clinical probability of significant cancer, and 5 being a very high clinical significant cancer. So what are the MR scan protocols that we use for multiparametric imaging of prostate? We have a T1 weighted axial image sequence, which is to look for post-biopsy hemorrhage, look at the periprostatic fat, and act as a baseline for post-contrast images. We also require a high-resolution T2 weighted sequence, and this is usually acquired at our center as axial, sagittal, and coronal across the longitudinal section of the prostate gland. Axial T2 weighted sequences also is taken in coronal and axial for the entire pelvis to look for the rest of the pelvic organs and pelvic bones. Diffusion imaging, now the recommendation is we need to have ultra high B value as greater than 1000 with corresponding ADC max. DWI imaging of the in axial sections of the entire pelvis is also recommended so that it detects pelvic nodes and bone metastasis. Also, multiparametric assessment includes the dynamic contrast enhanced imaging. Coming to the updates in PIRADS 2.1, they have tried to simplify the sequences, terminologies, and reporting. They have tried to say that T2 weighted images are the most important images while evaluating transition zones, whereas ultra high B value DWI images are required to assess the peripheral zones. The ultra high B values can be either acquired or calculated. Spectroscopy was not a part of PIRADS version 2, so spectroscopy is not done. And there is now decreasing role of dynamic contrast MRI. Also, the measurement of prostate volume has changed according to their recommendation, where the maximum transverse diameter is taken on an axial section, and the longitudinal diameter and the AP diameters are taken in the sagittal sections rather than the axial as we usually do. Something about the high resolution T2 weighted imaging. When we are doing a high resolution T2 weighted imaging, there has to be a small field of view between 12 to 20, thin sections of 3 mm or less with an in-plane resolution of less than 1 mm. All modern scanners now have an in-plane resolution of less than 1, like 0.8 into 0.8. There should not be any interslice gaps. Also recommended that at least 2 planes of prostate are imaged, meaning either an axial and coronal or axial and sagittal, so that findings on the axial on a T2 weighted image can be correlated on the corresponding sections in the other plane. Image acquisition coming to DWI with high B values. Now it has become mandatory if we are doing a multiparametric imaging of the prostate to acquire images with B values of greater than or equal to 1,400. It can go up to 2,000 when it comes to 3 Tesla. ADC maps should be generated separately with low B value set, where B values start from 50 to 100 and reach up to 800 to 1,000. So you have to run 2 diffusion sequences, one with an ultra high B value and one to generate ADC maps which have B values from 50 to 1,000. Again, the field of view should be small, 15 to 22, covering the prostate and seminal vesicles. The slice thickness can be as high as 4 mm, ideally less. In case of older scanners, there are significant artifacts that come when we have slice thickness of less than 4. So a slice thickness of 4 mm at least can be given so that we get good enough images that we can read. Another caveat that we have given when it comes to DWI imaging is there is no standard prostate windows. Anyone who has reported prostate MRI would know the wide variation of window settings that we play around while looking at DWI images. So the recommendation is that we have an internal standard where we see hyperintense lesions and correlate with histopathology, and then consider that hyperintensity on DWI as the control for a malignancy. When it comes to dynamic contrast MRI, as I've already said, there is now decreasing importance of dynamic contrast MRI. However, the requirements, if we are doing a dynamic contrast MRI, is a slice thickness of 3 mm, no gap. Ideally, a 3D sequence is required, and the temporal resolution should be less than 15 seconds, meaning we should be able to scan the entire prostate in less than 15 seconds. Modern scanners now can scan the entire prostate within 5 seconds to 8 seconds. And we should continue acquiring images up to or more than 2 minutes. Preferably, the image acquisition should be fat saturated, and post-contrast and pre-contrast subtraction images may be useful. Another key important requirement is it should have the gadolinium injection should be at a steady 2 to 3 cc's per second. There are centers where MR compatible injectors are not available, and that is one of the main reasons why dynamic contrast MRI the importance is going down, because they are not able to assess those images with hand given injections. Another important lesion that they have now asked us to diagnose is the central gland tumor. Now, earlier, like 2 years ago, if I were to report a prostate MR and on T2 images, if I come across a hypointense wedge-shaped area at the base of prostate, such as this, I would not report anything and would not give any importance to this, because this has been taught as the central zone, which is normal. This central zone is also usually dark on EDC. However, it is now recognized that central zone can also have malignancies. For example, as in this case, these are the coronal T2 weighted images where we can see there is diffuse marked T2 hypointense area within the left side of the central zone. There is asymmetry between the central zones, and this asymmetry is extending and infiltrating into the seminal vesicles. So this type of cancer is now important, and we are recommended to diagnose such condition, because even though the percentage of cancers is less than 5%, which arises from the transition that arises from the central zone, they are more aggressive, have a higher Gleason score, and have a higher rate of extraprostatic extension, as it can easily invade the seminal vesicles. They also have a high risk of recurrence. So this is now one area that we need to look at carefully while reporting multiparametric prostate MRI. Another area that they have asked us to look now is the area of anterior fibromuscular stroma. Because the anterior fibromuscular stroma is basically that, a fibrous tissue which would always be dark on T2 and show no signal on DWI or ADC. Now, if such an area is now showing hyperintensity on DWI and shows enhancement on dynamic contrast, then we need to look at it seriously, see for extracapsular bulge, because anterior lesion, about 30% of all anterior prostatic cancers are missed on MRI. Another relation is in the sectoral map. Now, sectoral map, this seems to be a complicated diagram, and we usually don't indicate the exact areas or try to mark exact areas. But what they have recommended is that it is easier to depict the lesions in such a sectoral map, so that it is easier for the clinician who then does a biopsy. The new addition is they have added a medial peripheral zone at the base of the gland. So now there is a total of 41 sectors, which is including the 38 in prostate, 2 in the seminal vesicle, and 1 in the prostatic urethra. Nobody actually uses this other than to depict the lesions. Now, coming to depiction of lesions, they have said that we can mark up to 4 lesions, with the index lesion being the one which has the largest axial diameter, or the one which has extraprostatic extension. Coming to PIRADS assessment, for assessing the transitional zone, the T2 score is the most important part. Whereas when it comes to assessing the peripheral zone, then DWI is the most important sequence. Suffice to say, if you are not able to get a good diffusion imaging for your prostate MR, then that study is probably suboptimal. The new changes that they have brought about when it comes to PIRADS version 2.1 is the dynamic contrast enhanced positivity. If a peripheral zone lesion which has a DWI score of 3 shows positive contrast enhancement, that lesion grade is bumped up to 4. Whereas in the transitional zone, T2 is the most important sequence that we have to assess, and followed by diffusion. So supposing if there is a T2 graded lesion in the transition zone which shows a diffusion of 4 to 5, then that lesion is upstaged. Similarly, a T2 grade 3 lesion in the transition zone, if it shows a DWI grade of 5, then lesion is also upstaged 4. We will see examples of these. So DWI image interpretation is common for peripheral and transition zone. Basically, if we see no abnormality either on ADC or high B value DWI, as in this case, it is categorized as 1. In case there is a wedge-shaped hypointensity on ADC or a linear band of hyperintensity on DWI, then such area is classified as 2. Now, if see a lesion which is markedly hypointense on ADC compared to rest of the gland, just disregard this lesion. If we see a markedly hypointense lesion on ADC compared to rest of the gland with no corresponding hyperintensity on diffusion, that lesion is graded as 3. Same goes vice versa, that if we see a DWI marked hyperintense lesion compared to rest of the gland with no much significant dark signal on ADC, also is categorized as 3. However, if we see a lesion which is very dark on ADC and also shows hyperintensity on DWI, then such a focal markedly hypointense lesion on ADC or hyperintense lesion on DWI is characterized as 4, provided it is less than 1.5. If that similar looking lesion, which is extremely dark on the ADC compared to rest of the gland and shows significant hyperintensity and has a measurement which is greater than 1.5 centimeters, then such a lesion is graded as 5 on DWI. Also to note that peripheral zone lesions are measured on ADC values and the transition zone lesions are measured on T2 images. So as already said, when it comes to assessment of the peripheral zone, the DWI images are the most important, and AD and T2 images really do not have much a role other than localizing the lesion. So I'll rush through this in the sense that peripheral zone is usually homogeneously hyperintense on T2, and so that is marked as 1. If there is slight wedge band-shaped hypointensity, which is not having any mass, then it's probably characterized as 2. And a peripheral zone which has indistinct mild hypointensity, that is characterized as 3. Whereas if there is significant T2 hypointensity with probable extracapsular bulge, it's characterized as 4. And if such a T2 hypointense abnormality in the peripheral gland, which has a dimension greater than 1.5, is characterized as 5. But measurements, the categorization on T2 for peripheral zone lesions is not important. Where it is important is in the transition zone. Now look at this image. This is the typical appearance of a benign prostatic hyperplasia. This is also called as this image is also called as organized chaos, in the sense that we see multiple lesions which are reasonably well circumscribed and nodular, has heterogeneous T2 signal intensity. There is enlargement of the transition zone with thinned out peripheral zone, and we can also see extruded nodules in the peripheral zone. Such areas or such a prostate, scoring is usually not done, and a DWI or a T2 score of 1 is given. So basically, a typical BPH nodule should be round, completely encapsulated. As in this case, the lesion may be hypointense or heterogeneously T2 hyperintense, which has a well-defined capsule, well circumscribed. Such a lesion is given a score of 1. Now, a category or T2W category 2 lesion is one, as in this case, where we see a homogeneously T2 hypointense lesion which does not have a capsule. So this is an atypical nodule. Another lesion here, we can see a well circumscribed hypointensity around the nodule, but at some areas that capsule is not well defined. This is also an atypical nodule. Also, areas between the nodules. Example, in this case, if this is one nodule and this is another nodule, there is some hypointense area which is wedge shaped between these areas. This is also characterized as 2. However, when we have a similar lesion as this nodule, which is shows kind of a well circumscribed capsule, homogeneously T2 hypointense, but shows marked hyperintensity on DWI and marked hypointensity on ADC. Such lesions are upscaled and upstaged to category 3 lesions. This is the schematic representation where a well circumscribed nodule, which is homogeneously T2 hypo or heterogeneously T2 hyperintense lesion, is 1. Whereas if the capsule, either the capsule is indistinct or the lesion does not have a capsule and does not show any significant abnormality on DWI or ADC, is still categorized as 2. However, if such a lesion which has an indistinct capsule or does not have a capsule but shows hyperintense signal on DWI and a dark signal on ADC, should be upstaged 3. Coming to category 3 lesions, when we see a heterogeneous signal intensity area such as this, which does not have a well-defined margin and does not qualify as either 2, 4, or 5, then we can categorize this as 3. However, if such an area shows a diffusion score of 5, then this transition zone lesion is upstaged to 4. Similarly, in this case, we see a lenticular shaped, not well circumscribed, homogeneously T2 hypointense area in the anterior fibromuscular stromal area. This lesion would be characterized as transition zone 4. And if it is greater than 1.5, then it is characterized as zone categorized 5. Coming to dynamic contrast scoring, if we are able to find a lesion, we localize a lesion either on T2 or DWI, and that lesion shows either does not show early or contemporaneous enhancement with the rest of the gland, meaning that lesion does not show early contrast uptake compared to rest of the gland, then it is considered, that lesion is considered as DCE negative. However, if that lesion, as in this case, in the peripheral zone, we have localized a lesion in the peripheral zone, which shows early contrast enhancement on DCE, then this is a DCE positive lesion. And the importance comes when DWI lesion, DWI3 lesion shows contrast enhancement, then we have to upstage the lesion. Now, if it's a frank malignancy, we will be able to see the lesion extending outside the prostatic capsule, as in this case, where this is at the level of the base of prostate. We can see that there is a homogeneous T2 hypointense area which is going out of the prostate capsule, infiltrating the neurovascular bundle. And dynamic contrast shows homogeneous early enhancement. This is an example of extraprostatic extension. Similarly, if we see a lesion which is hypointense in the peripheral zone and causing hypointense signal within the seminal vesicle, as in this case, this is the coronal image. You can see the peripheral zone lesion has infiltrated into the seminal vesicle. That is stage 3. That is a stage greater than 3. You can also on coronal image see lymph nodes, and nodes which have a short-axis diameter of 8 mm or more is considered as suspicious. Once in a while, we get patients who have extensive metastasis. As in this case, we can see ill-defined T2 hypointense bone marrow changes throughout the pelvis and the intertrochanteric region of the femora. Mind you, because prostatic bone metastases are sclerotic, these lesions will be dark on T2 and T1 images. So finally, the ACR has given a reporting template for PIRADS which makes our life easier and is a good guide to reporting a multiparametric prostate MRI. But the elephant in the room is prostatitis. Whatever said and done, we will in our routine practice call prostatitis as malignancies, because example is in this case. Here we can see a lesion which is in the right side of the peripheral zone. Because it's a peripheral zone lesion, we would immediately look at diffusion, and on diffusion the ADC shows a dark signal and has DWI signal intensity which is greater than the surrounding parenchyma. So we cannot ignore this lesion. This lesion becomes a DWI 3 lesion. And when it comes to peripheral zone, we have to look at dynamic contrast images also. And in this case, that lesion showed early contrast enhancement. So the grading of the lesion changes from 3 to 4. So that means a clinically significant malignancy is suspected. However, in this case, the authors have said, because this lesion has an ill-defined wedge, it has a wedge-shaped T2 hypointense area, and on sagittal sections that involved area gland appears to be atrophied compared to the opposite gland, that's probably a subtle sign suggesting that this lesion could probably be prostatitis. But this is one of the lacunae of PIRADS imaging. Another example, this was a case from our hospital, where we can see a ill-defined T2 hypointense area, but we look into the diffusion, and on diffusion we can see there is a hypointense signal on ADC which was bright on DWI and also showed early post-contrast enhancement. So we had to give this lesion as PIRADS 4. However, on transsectal biopsy, the biopsy report said to be normal prostate. When it comes to the pathology reports, if it is case of chronic prostatitis, the final impression in that report would still be normal prostate. However, if you read the subject, the descriptive part, they will say inflammation, infiltrative lymphocytes, which suggests chronic prostatitis. Coming to another now important terminology called as the biparametric MRI protocol. We now come across lots of elderly patients whose renal functions are not very good, and so there is always a question of giving contrast in such borderline chronic renal failure patients. So because the weightage of dynamic contrast MRI in PIRADS version 2.1 has come down, there is now a concept of biparametric MR, where there is only diffusion and T2 imaging which is done for the patient. However, we must realize that without giving contrast, it is this kind of biparametric MRI is not recommended if the patient has had a prior negative biopsy and has an unexplained elevated PSA or has a fast doubling PSA. Also, if a previous imaging has been done and that is biparametric MRI, then the next imaging that he should undergo is ideally a multiparametric MRI, which includes injection of contrast. In case of prior prostate intervention and strong family history also, it is recommended that we do a multiparametric MR. But considering the high demanding clinicians that we have, so if in case there is contrast cannot be given, we can still proceed to do a biparametric MRI for the patient. This is a slide that I borrowed from Professor Padani. He's one of the major proponents of MRI, multiparametric MRI in prostate. So the fallacies or the lacunae in PIRADS imaging is 50% of men who have positive MRI a PIRADS score of 3 or more actually has a negative histology or a insignificant cancer. Also, the performance of radiologists in practice does not match those seen in high volume centers. Reporting PIRADS or multiparametric MRI of the prostate is a steep learning curve, and you are supposed or considered to be an expert if you have at least reported over 300 cases. The expertise level is advanced if only you have reported more than 1,000 cases. And I'm not very sure how many people in our group or in Kerala would have reported more than 1,000 prostate MR, probably in cancer centers, probably. Also, it is said that 30 to 50% of patients who get gadolinium contrast are not benefited. There is also the problem of gadolinium deposition in brain, which is now becoming important and a significant detriment to giving contrast. Also, PIRADS is time intensive to report, and also it is difficult to plan for an MR fusion biopsy. So currently our status is our patients have access to multi-parametric MR of prostate imaging anywhere in Kerala now. However, we are now at the stage where we need to up the quality of our reports and have a good accreditation and a interdepartmental screening method so that our reporting is up to mark. And finally, in after a few years, probably we will be able to take on fusion biopsy and convince our urology clinicians that fusion biopsy is the way to go for detecting prostate MRI malignancies. A word on the road ahead, as AI and deep learning is the prime terminology that is coming up. There is this article in Radiology which has looked at deep learning versus clinical PIRADS assessment, wherein we can see that such a deep learning and AI will help in the in decreasing the interpretation time. But I'm not so sure how significant is the decrease in interpretation time, because anywhere in Kerala we'll probably be issuing the reports within about 6 hours, whereas in Europe and America it would be 2 or 3 days. However, AI would obviously help when it comes to the increasing the performance in less experienced readers and also decreasing inter-observer variability. Another sequence that has I came across is this simplified luminal water imaging technique, which is a heavily T2 weighted multi-echo sequence, which will detect the quantity of water within the peripheral zone. So there is fluid which is secreted by the stromal and glandular tissue, which is surrounded by the stromal and glandular tissue. And as malignancy progresses, that water content within the tissue decreases. And so it will give a darker signal in this simplified luminal water sequence. This is in the experimental stage, and they have tried out just basic studies on this. So in conclusion, increasing and expanding the application of parametric MRI, especially in prostate, is very important for us as radiologists, and we need to keep updating and aim to narrow down the inter-observer variability with pathology correlation. And finally, we must aim to do fusion-guided biopsies in the near coming future. Thank you.